Welcome to this presentation titled Barriers and Facilitators to Scaling Up of Neurosupport, a novel model of neuropalliative care. More than 86,000 patients have a long-term neurological condition. Palliative care is usually not available to these patients until they commence the last year of life due to lack of funding. Neurosupport is a care model piloted at our institute that addresses the gap in patient-centered care, caregiver support, and essential medical surveillance on these patients. It includes 7 components. We conducted semi-structured interviews with healthcare professionals to understand the barriers and facilitators to encourage the adoption, sustainability, and spread of neurosupport. Our interview guide was created based on Theoretical Domains Framework, or TDF. TDF is used in healthcare research to understand potential barriers to change at an individual clinician level and inform subsequent strategies to overcome modifiable barriers. We deductively and inductively coded the transcripts. Code mapping was done to distill codes into higher order codes and themes. 3 cycles of code mapping were completed to arrive at the final themes. 21 out of 78 eligible healthcare professionals agreed to be interviewed. Eligible healthcare professionals are involved in the care of long-term neurological condition patients. Over half of those interviewed were doctors, with the remainder divided between nurses and allied health professionals. 5 themes emerged. For this presentation, we wish to highlight a few surprising yet important findings. Scan the QR code on the bottom right to access the themes and codes. Please note that these are our preliminary results as analysis is ongoing. There was a lack of clarity for implementation of the Neurosupport model, where interviewees wanted more details about Neurosupport. They had thoughts on how to conduct it, when is it appropriate to begin it, who to provide Neurosupport to, and where to provide Neurosupport at. They also felt that Neurosupport components should be prioritized according to patients' needs, rather than being applied wholesale. They also suggested for tiering of care providers, for example, primary care providers with basic core competencies in advanced care planning, basic symptom management, and essential medical surveillance. The involvement of non-neurologists is highlighted in the theme Lack of Integration of Health and Social Services, as patients eligible for neurosupport may not all see neurologists. This is in line with this year's conference theme on building community and breaking barriers. Interviewees spoke about providing care outside of the hospital, at home, or in the community where it's most convenient to the patient. This can be done via video consults or forming or collaborating with home and community-based services. To further break barriers, one could collaborate across institutions, although that would be challenging. Interviewees also gave feedback that the current model places the burden on the neurologist. While traditionally, doctors have been responsible for treatment decision-making, they question if this should be so in neurosupport, which is multidisciplinary. In the next theme, resource-intensive and unaware of available resources, interviewees shared that each neurosupport actor in multidisciplinary care has a collaborative part to play. So perhaps the neurosupport model could reflect multidisciplinary team processes better. This idea is substantiated by the allied health interviewees, who also say that they are already providing neurosupport, and not just at the level of individual multidisciplinary team input component. Interviewees also spoke about the role of the non-clinician in the team for administrative duties, such as setting up appointments, which are currently done by clinicians. Lastly, caregiver support usually refers to family caregivers. However, under the theme of build rapport and support the patient, family, and caregiver, interviewees emphasize the need for supporting paid caregivers. This is important as in Singapore, many working-age people go to work, so much so that 1 in 5 households have a live-in migrant domestic worker who manages everything in the home, from household chores to caregiving. Patients are thus reliant on these paid caregivers, whose well-being should be looked out for. Before neurosupport can be scaled up, the revised model and program needs to be piloted. More effort is needed to educate and raise awareness about neurosupport. We also need to do more to integrate hospital and community health and social services. And manpower training and resources will be needed in place to scale the program. The findings will impact how we will select implementation strategies based on an implementation science framework.
Thank you very much for that poster and that presentation. I was wondering, have we got a similar issue of a lack of understanding of perhaps what a neuropalliative care approach would be amongst the professionals that we were hearing about in the previous presentation?
Yes, yes, I think there's still very much a thought that palliative care is for the very advanced patients. Although quite a number of my interviewees actually mentioned starting palliative care right at diagnosis. And many of them also brought out the nuance that it should be actually disease specific. So some diseases, they feel that it should start at the beginning, and some diseases maybe not. Or maybe a little tiered kind of approach for the palliative care inputs, like little bit for those with very long prognosis and with not very many needs at the beginning. So I think it was quite, to me, quite surprising that there was already so much insight on palliative care by my fellow neurologists and their teams.
Do you think in the population of Singapore, in the patient population, there would be similar uncertainties about palliative care?
Yes, I think that many of the patients still view palliative care as quite for the dying, unfortunately. Yeah. Yes, but I think that this is also okay. So as a result of palliative care being very tied to dying, I have renamed this whole program Neurosupport. Yeah. So I think this, when we call it Neurosupport, interestingly, patients can imagine that it's just an additional service on top of what they're receiving. And so I find that this naming actually helps reframe what palliative care means. Because after that, they Google me and they notice that I have, my specialty is palliative care. So they're okay with it after that. Yeah, thank you.
Thank you. And if you had one message, what would it be and who would you give it to?
So I think because this is the International Neuropalliative Care Society, my one message is actually that I'm hoping for sharing and collaboration because I think we have a lot to learn from the international community here. The Singapore development is quite still quite at the beginning stages. And I think that we definitely can benefit from the educational resources for not just patients, families, but also our formal and informal caregivers.
Thank you very much indeed, Kexin.
Thank you.